Hi, good afternoon, everybody. It's Friday, the last Friday of the month again. These months keep coming around really quickly. Today's session, I'm really excited about learning a lot from our panel members. We'll all do our introductions in a minute. These Friday sessions at the end of the month are all about innovation and how can we genuinely change stuff, not just talk about change, but actually get stuff done. Today's going to be a really practical session that everybody on LinkedIn can get involved with, and we'll explore this a little bit later on. We want insights from the ground, from people doing this work, with insights that have been built up over years that you know a lot about that can support this change that Rachel's leading. So we'll get more into that about how we're going to do it a little bit later, but quickly I'll just do a quick introduction and we'll each do 60 seconds about ourselves, and then Rachel's going to kick us off with this project and what we're working on. It's all predominantly around urgent care, emergency and urgency care, and there's a real focus on how do we get our heads in the middle of summer around winter planning and making sure we manage winter pressures a lot better than we usually do. So I'll start off with me. I'm Anthony Lawton. I'm the Director, Chief Exec of Fit to Care and Insight Genie. My passion is flow and care improvements and really listening to the front line and to people that are doing the direct work, that only through that listening can we do a good job. So I'll hand over next to Mark.
Hi, I'm Mark Wilkinson. I've had 15 plus years of experience in the NHS, ranging from cancer services to gynecology to child health, so planned care and a lot of unplanned care experience around, in particular around transformation, managing flow. And I also have my own health consulting company, and I've done a lot of work around integrated care models, which I think is more than appropriate for this discussion and the NHS generally.
Fantastic. And just before I hand over to Ben, I forgot to say in my intro piece, please, in the audience in LinkedIn, please do put some comments in and requests for answers from the panel. We can see any questions that come up live in our little dashboard. So please do get involved. That'll make the session a lot better. Over to you, Ben.
Thanks, Anthony. So I'm Ben Williams. I come from a background, I have 10 years plus of evaluation and analytics in healthcare, mainly looking at quality improvement programs, pathway design, one of which was looking at usage of winter funding, and in particular when the ARI hubs came out. So I got chatting with Anthony on LinkedIn and he invited me here. So hopefully I can be of use.
Yeah, fantastic. Just a bit of background to that. I just thought, let's try these practical bottom-up reform processes. And I just thought, let's start with emergency care, put it out there, see how many people are interested. And thankfully, I got 3 brilliant panel members for today. So over to Rachel, so you can introduce yourself and then kick us off with the project. Rachel, that'd be great.
Brilliant. Thanks, Anthony. Thanks, everyone. So my name is Rachel Clark. I've been in the NHS for over 25 years, and my background started off in diagnostics. Then I had a brief stint in a clinical setting, and probably for the last 10 years now, I've been working in operational management. So I've got backgrounds in planned care, cancer services, and most recently, urgent care. And part of that role has been transforming and moving our 2 hospitals to our new purpose-built Midland Metropolitan University Hospital here in Smethwick, Birmingham, which we opened back in October 2024, bringing together the 2 acute sites, so 2 EDs, 2 acute medicine units, and all the different specialties under one roof, something that the population of Sandwell and West Birmingham have been waiting for 20 years. So it's been a real eye-opener and a real challenge, but also a real pleasure in delivering and seeing that dream come through to fruition. So for the context, the Midland Metropolitan University Hospital, it does sit within Smethwick, and it serves, as I've said, the population of Sandwell and West Birmingham. Our population is a very diverse population. It also has a high level of deprivation. So bearing that in mind with some of the challenges we have with how we engage with our patients and how we best support their physical and mental health needs. The premise of our design for our urgent care level 2 in our new hospital has always been around right care, right patient, right time. And how do we best manage the patients that present to our hospital, and how do we work with our support services and our key stakeholders in primary care, mental health and social care settings to best manage the demand of the population and the community that use the facilities. So at the moment we have, as I said, a purpose-built unit. We have a very large ED department that we see around 450 attendances per day, 130 ambulances. So we are seeing the most ambulances in the Black Country footprint. Our physical footprint within that department, we set up in a zonal arrangement within ED. So ambulance assessments, resus, majors, cubicle setting, monitors. We've got minor injuries and what we're calling our smart triage area for those patients that present from a walk-in perspective. Within that second floor as well, we have straight to test pathway. So we have straight to cath lab for those patients presenting with acute MIs. We have straight to assessment for stroke patients. We've also have an opportunity to stream patients through to our same day emergency care centres and our GP front end service as well. So we have got some the startings of streaming so that we can try and redirect patients who do present to the front door who may not necessarily need the input of an emergency care physician. So I think the real challenge for us is when we're looking now at winter. This is all working really well at the moment, I have to say. In summer, we're hitting the constitutional standards. We're hitting our 78% for our performance. We hit our 45-minute offloads for ambulances. But how do we best set ourselves up for when that system is under pressure with our winter challenges? And I think I'm particularly keen to understand how we work with our primary care providers to best support the needs within primary care as well. And how do we bridge that gap between their understanding of the pressures in acute and our understanding of the pressures in primary care?
Yeah. Okay. Brilliant. A brilliant context setting for us. I'll just give everybody a bit of an overview about Insight Genie and how that can help us with this process. And what's just occurred to me, Rachel, going through that is we might need to update the context within Insight Genie so that it's a bit more specific to give people more of a view, which we can maybe update straight after this call. But if people can just bear that in mind. Again, to people on LinkedIn, please do put your comments in the chat so that we can respond directly to you. But I'll just give you a quick overview now about how do we practically take from where we are now and progress this project by gleaning more insights and knowledge from relevant people in the system. So if I just open this up, come back to the first page. I don't know if that will be any bigger. So this, what I've done is I've set up an AI-driven system in order to specifically capture much more knowledge and insights from many, many more stakeholders that typically we don't get to engage with because it costs too much to do these qualitative reviews and it takes too long. So the last one that I was involved with in the NHS took over 6 months to capture this sort of information, and it cost tens and tens and tens of thousands of pounds. I'm looking to completely change that process so it's fast. We can do this within it. Well, this Insight Genie will close next week. And from that, within hours, I can generate all the reports that can feed through to Rachel to give her lots of insights and food for thought about how she progresses this and how she manages this challenge. So this is just an example. You can't read it, but you can just see that it's very simple. So actually the link to this is in the chat, high up in the chat that I posted about an hour ago. So that anybody watching this and the video playbacks, if it's before next Friday the 4th, please click on that link and make your contributions, share your wisdom with us because that's what we need. But essentially it's a one-pager. This sets the context for what we're doing and why we're doing it. It's saying that it's anonymous. There's no data protection issues because with no names, no emails are captured. And then essentially just 3 very open questions. on the lines of, what are the problems and the challenges from your perspective with your experience? Second question is, ultimately, where do you want the system to be? What's the ideal state? And then the third question is, given where we are, given the ideal state, what do we do to bridge the gap between those two states? And again, from your experience, you will have lots of ideas about what we should do and how we should do it. So essentially, that's the three open questions. It's not death by survey, 40 questions set up by managers who think they already know what the problems are. This is much better. It's much easier to do. And it's much less bias involved. We just want the salient points that are making your life in this space a misery, because that's what we can then focus on to improve. And then what Insight Genie is doing, again, sorry, this is too small to read, but we've got three processes, if you like, to the Insight Genie system. This first one, the one that you've just contributed to as a stakeholder, it's all about how do we get to learn all the key themes that are coming through, but also what language is being used. Who are these stakeholders? How do they speak? What language do they use? And that's also, we can get into the behavior change of all this and understand that if we want to engage with these key stakeholders, we've got to learn about where they are, the language that they currently use, so that we can use that to communicate properly going forward. So that's the first step, pulling out all those key themes and understanding those key problems and the new ideas and that sort of thing. I then take those key themes and all that knowledge and use that to then do a deep research on the web. So all those key themes that are coming out, what's the international research associated with those key themes? What are the use cases around the world, relevant organizations? And what's the academic research, particularly we're drilling into return on investment type research to validate all these key themes and the case studies that are driven by those key themes. And then the third Insight Genie report is essentially pulling together all the knowledge from both of those data sets to produce three really nicely formatted reports. So we've got an exec summary report that Rachel will get hold of. We've then got a strategy report and then a key implementation report. And all of that is pulled together into three nice reports, but you've got all the detail and the background appendices to feed the summary reports. The summary report looks, this is just the first one, the exec summary one, is just a nice looking report that any board can sort of pick up. So hoping that Rachel will get hold of these three reports and all the background workings, and it'll be a massive step forward for her in terms of her workings to actually get stuff delivered. So that's the background to why this is practical and how the audience members, whether you're watching live now or whether you watch this recorded over the weekend, can get involved. Click that link to go through to that Insight Genie page, and let's get gleaning your insights from the ground up. That's the plan. So I know Mark's done a test for us with this just to check it's working. So I don't know if you just wanted to give a quick update, Mark, on that, and then we can get into the...
Yeah, I mean, it's the simplest questionnaire survey, however you want to describe it, I've ever done. So like you say, 3 questions. I think the hardest bit is really articulating, putting into words exactly what the problems are. So you know what the problems are on a daily basis, but they're very much interlinked. They're quite complex as well when you step back and look at them. Yeah. So that's the only thing. It requires a bit of thought to actually get the most out of it, but it's very simple process.
It's a really important point, that, because I often get asked, and I might do this as a development piece for later on, is, can we just have an audio input so I can just talk it through?
Yeah.
And it is something we could do. I often use transcripts and load the transcripts into it this way. But actually, I find, and my experience is that just the physical act of writing, something happens and it forces you to think a little bit more deeply about, okay, I'm not just blurting stuff out. I've got to think before I put this down, and it just creates a bit more structure and a bit more clarity in your own head, actually. Yeah. Before it goes down, so it is really valuable doing the writing piece. Yeah. So the more of that is, the better.
No, it is invaluable. Absolutely.
And what, again, a quick one before we get into the detail with Rachel, is what I'm trying to do is really reduce the number and time of meetings, where often they're not productive. It's just a talking shop. So instead of having an hour and a half meeting, and we come out of a meeting, we go, I'm not quite sure we decided anything there, or we had any plans, or we really got anything down on paper.
Yeah.
Forget the hour and a half. Just spend 15, 20 minutes where you're really thinking about it. Let's get people doing that. Save a lot of time. Get more quality output out of those brains, because there's a lot of brain power to tap into.
Yeah. And also, Anthony, I think there's coming from sort of the analytical point of view, trying to come up with understanding what are the questions that we're trying to answer. Actually, that risks introducing bias, and here I am in my ivory tower, I don't understand. So actually, by having just these 3 questions, you're almost sort of taking that element out of it, and hopefully getting much closer to, I suppose, the truth.
Yeah.
That's what really kicked me off with this, Ben. I was doing a project for NHS England, and I went to interview a load of nurses, and the things that came out were like game-changing things, would never have come out of a traditional survey, because a traditional survey has people like me at the top thinking they know what the issues are.
Yeah.
Load those questions. The people on the ground answer those questions, but forget to tell you about, actually, we used to have a car parking permit from the council. They said that needs to now be £100 a year. My NHS team said we haven't got a budget for it, so I can't have it. Now, instead of parking outside the door, it can take me 20 minutes to park. I've only got 15 minutes to see the patient. That's the sort of stuff that I want to glean, because that's the difference between success and failure. But the guys at the top writing the questionnaires just can never know that level of detail. It's what the open questions is the essential bit.
Yeah.
It's like, what is creating most pain for you? And then once we can pull that together and augment it into a report that we can get our heads around quickly from hundreds of people, that's the plan.
Yeah.
So that's what we're looking to do, everyone, for Rachel, for this project, is glean all those insights, like the car park permits, feed all those through, have then a bunch of reports, exec summary, strategic report on the back of all this, and an operational implementation report. And hopefully maybe we can report back, Rachel can report back in a month's time and go, that was helpful. That's the plan. So we haven't had any questions from the audience yet then. So shall we just get stuck in, and Rachel, you start getting, and I guess predominantly picking Mark and Ben's brains on all these issues and where we get started and what they think the key themes are going to be.
Yeah, absolutely. So as we were having a pre-chat, weren't we, around, actually, as you've just described quite rightly, Anthony, we've got all these data sets, and I've always said to my ops managers, actually, your dashboards will tell you one thing, but the soft intelligence is what you need to go and gather. And I'm hoping that, this is as you've just described, the tool that will bridge that gap. And we're not designing winter pathways or pathways that will survive the test of winter and beyond. We're not doing that and making all that effort, but not having the input from the staff and our service users as well. So I guess it's trying to understand, how do we best engage our primary care users, for example. We've got services within secondary care that will help admission avoid patients. So we've got a single point of access service, for example, that is accessible to the ambulance service, that is accessible to GPs. That service is staffed with our trusted assessors, and they're best placed to describe actually where the patient needs to be referred to. So not necessarily ED. So we need to get past the ethos of the only place that's open all the time is ED. There's alternative pathways. How do we really push that message out there, that we've got pharmacy first, that we've got access to virtual wards, that we've got access to urgent community response teams? How do we engage the system to best utilise the tools that we've put out there? And I'm very keen to understand, whilst we think it works wonderfully in secondary care, what does it feel to be like the other side of that fence, and what are the barriers that are stopping people from utilising it more than what they currently do?
Yeah, I've some thoughts have popped into my head, but shall we start with you guys first? Mark, do you want to feedback?
Yeah, I mean, yeah, I mean, we were talking before we started, and it is key to understand the pressures that primary care face. I think that, it's, the NHS is one big organisation, but actually, it's not consistent across the board. So certain areas struggle in terms of primary care, and other areas may not struggle. So it is a bit of a postcode lottery. So it's about, what sort of primary care services are operating currently within your region. Do you have lone GPs? Is there a very diverse population? Do they fully understand the what ED is meant to be, represent, etc.? So I think there's a lot of things that need to be taken into account. I think, it's very easy. I like yourself, Rachel, I've worked in secondary care for a long time. It's very easy to actually jump to conclusions about primary care, but actually not understand where they're coming from. So, we need primary care in the room, most definitely. And that's one of the things we were talking about when I was at the Royal Free. So we had a winter planning session, and we did have primary care there in attendance, actually. So it is about almost like front loading the system. Let's look at it now. In fact, we should have been probably looking at it in April, etc. But I guess it's never too late. But yeah, we just need to understand what their pressures are, what would help them. I think we need to also get away from this default position is ED. And that's what I found in York, certainly. And I mean, I guess we can come on to NHS 111 eventually, but the algorithms seem to be set up towards ED. So it's about, how do we inform that discussion around that to change it if possible.
Did you implement anything that came from that primary care conversation? Well, I mean, I suppose in the context of the economics as well, with the finance situation that we've got with, someone asked me the other day, what's our winter budget? I was like, there isn't one. So we've got to do best with the resource that we currently have.
Yeah, and not really. I mean, I think like you just articulated, we've got budgets that we need to stick to, etc. And it was more sort of a, what are the pressures from primary care? What are the pressures from secondary care? Can we talk more? Can we sort of put like a mechanism in place that actually enables a dialogue across the system? So you're talking about mental health as well. What is it that can be done to actually prevent the mental health tendencies in ED? It's a bigger issue regarding the number of beds, of course, for mental health patients and that sort of provision. But it's almost like, the conversation started. I don't think we reached any major revolution or breakthrough, but I think it's good to just get people in the room. I almost got the impression that it was just like, let's understand each other. But I think that's a platform upon which to build in the future. Mm-hmm. It's not just about understanding, it's about what do we do about it. And I didn't think we got to that stage.
Yeah. And of course, in the middle of that is the patient that's been sometimes ping pong backwards and forwards, isn't it? And actually, I think that's the other element that we, as in our positions, need to keep reminding ourselves: what does it feel like to be the patient in the systems that we're designing, and how easy is it for that patient to navigate their way through? To your point about 111, 111 say it's your GP, you can't get through to your GP, then you sat back waiting with 111. It's only natural then that patients will just think, well, I'll just rock up to the front door of ED because they're constantly open. So
No, that's right. I mean, I spent some time in reception. I thought it was a good idea. I mean, we talked about this before. It's about that soft intelligence. I mean, you know, the data can tell you one thing, but what's behind it? So, you know, I sat there and I you know, obviously was observing the type of patients that were coming through the door, and a lot of them were from the GP, from 111, etc. And very frightened people, you know, patients didn't know what to do. Some of them turned out to be really serious, so it's as well they did come. But of course, the majority could be seen in a different context. And I guess it's about, you know, is that algorithm appropriate? You know, does it need to be reviewed? Because essentially, it is an algorithm. I think that people are just reading from. You know, have you got a high temperature? Have you got chest pain? Have you got etc. And I think that, you know, GPs are under a lot of pressure as well. And I think there is this sense that, not sure about this, send to ED. Now, if you're looking at, say, I know when I was in child health, the registrar had a phone. So the GP used to phone the registrar or the consultant and then just run it past them. Does this patient need to come in, etc. So I think that's quite helpful, but, you know, that's not always easy to implement.
Mm-hmm.
Rachel, I'll just give Ben a time in a minute. What's popped into my head is, given that you've already got a nice system of the streaming, where you're filtering people out of ED because there's different needs there, my gut feel is, could we quite easily capture more data on those cohorts and almost do almost a dictaphone per patient and say, this patient's come in and the background is this, and the reason they've come here is this. And it probably wouldn't take us too long to get a good, solid picture of the cohorts that are typically coming through and the types of reasons why they're coming through to ED, as opposed to community care or primary care. And it probably wouldn't take us too long to collect a nice, rich data set of, we've got a real sense of size and scale of what's going on, and these are the key themes.
Yeah.
And then that's the way, perhaps that's the way to engage with primary care and saying, how can we help you with these? Because we've got a real sense of, these are the key themes that are coming on. These are the needs that are not being met out there.
Mm-hmm.
And from that, we might even then be able to go, given the size and scale, perhaps we need, you know, another team here. I don't know. I don't want to preempt what that might be, but I would imagine that wouldn't necessarily be that difficult to do. I found the dictaphone method to be really good.
Well, we've not tried that. We had e-system back in 2021 at our previous site, who did do a 24-hour audit of all those patients that presented to our ED at the time, and 85% of those patients did not need the input of an ED. On the back of that, we literally were just about to open our urgent treatment centre, so I got them to re-audit after that, which did show that, again, we had managed to successfully divert a number of those types of patients then to an urgent treatment centre. But still, the area around opportunity was around that same-day emergency care pathway, which is, as we said, if you can get the patient into that area. So if they do present to ED, you're best managing them once the patient is through the front door. But, you know, as you said, someone said in the chat, the system it's a huge system, isn't it? And it's a huge system problem that we're not going to fix in this conversation. But how do we start to engage at the beginning of the pathway rather than starting the emergency care pathway as the front door of ED? We need to start within primary care, community, you know, social settings, to be able to best advise patients where to go, and then only use ED when you actually need ED.
Yeah, that's right.
Yeah,
no,
absolutely. I don't know if we should pull up a few of these questions, because we get some good questions coming through now. I'll start off with the first one from Alan. Thanks, Alan. Yeah, as you've just said, Rachel, we're not going to cover it all in this call, but we need to do less talking, as I sort of introduced, less talking and more getting stuff done and understanding what's going on and then doing something about it, I think, absolutely. And then we've got people talking about flow in this call, which is absolutely brilliant. That's what we've got to do.
Yeah.
And this rarely align piece as well. I've written a book on this, my book on the shelf there, if anybody's interested. I've interviewed a load of nurses for this, which blew my socks off. Really powerful testimonies about what's going on in the NHS. But my greatest feel is that everybody's so pressured that we're all working in our own little silos.
Yeah.
And my personal experience as well about my treatment was the GP just didn't have the time to sit with me properly to get a proper diagnosis. And then I'm 2 years through secondary care, lots of cost, lots of failure demand, not a good service for me at all. I believe an extra 5 minutes of going through my actual case could have avoided all that. And it's not because the GP is terrible, it's because the GP is really pressured. And it's easier to push onto another silo than to try and deal with it yourself, because you just haven't got the time or the capacity or the headspace to do it.
Yeah. Can I just say what Neil has just brought up is absolutely correct, that it is about the system being quite siloed. So each part of the system has its own priorities, agendas, etc. And they rarely align, basically. So, I mean, he's hit the nail on the head there.
Yeah. And Rachel picked up on this earlier. Sorry, Ben, you come on next. It's about focusing on the patient, isn't it? Because if we really focus on the patient, I'm going to put the extra 5 minutes into that diagnosis, piece, and I'm going to make sure I do a really good handover to the next person in the flow, as opposed to, off you go. I've not completed that handover properly, but I'm going to tick my boxes. But if you focus on the patient, everything changes, doesn't it? The whole mentality changes, and you reduce a heck of a lot of rework because you just get it right first time. That's the key.
Mm-hmm.
Yeah. Sorry, Ben.
Yeah, so I was just going to come in on that sort of flow element. So some of the things that I've looked at in the past, so there are elements that I think, Rachel, you've got things similar. So within hip fractures, one of our local trusts had actually had an entire different pathway. So technically they go through the geography of the emergency department, but actually they're immediately looked after by orthopedics. So that's sort of, I suppose, one element. Something else that we've looked at was when some respiratory hubs were created. And I don't think this is necessarily going to help you as such, Rachel, but I think what is important is thinking about if you're creating a specific response to a particular actual or perceived issue, or so in this case it was sort of respiratory diseases in winter. If you create an extra place, maybe closer to home in the community, the sorts of buzzwords we keep hearing about, actually what you're doing is then assigning a whole lot of resource to that. If that resource then can't be at close to 100% capacity, either because the spike isn't quite as severe as expected, or maybe because it has to necessarily be reactive, it can't be operationalized in time. Actually, you're risking there creating the opposite effect of taking resource out of an ED, whereby it can to some extent take the all-comers and actually create inefficiencies by assigning it somewhere else. The other thing I just wanted to quickly pick up on from something that was said earlier is about the idea of, can you do a spot check to understand actually what our patients' needs? I think that's a really, really good idea. But if we're thinking about winter pressures, if you were to do that now in the middle of summer, then your case mix is going to be very, very different. So just, I suppose, just a thought about making sure that you're doing it at the right time, so that that data you get out of it can then be used in the use case you're thinking of. So, winter pressures.
Yep.
Yeah, absolutely.
Can I jump on one of those? Sorry, one of the comments in the chat there, is it John Paul? I think that's a really people-centered comment that I'd like to
I'll pull that up.
Yeah.
And I noticed that Alan said, can he join? And we've got a space, so he could join. I know he'd be doing make some really good contributions. So I'll just leave you guys with this comment while I try and find the link for Alan.
Yeah.
Okay, so are you taking that from a patient point of view or a clinician? Because I think that could be taken. I could take that both ways. Because I've had this fed back when I've spoken to clinicians as well. Actually, the volume of patients that they're seeing does impact on how they make their decision about that patient as well. We've seen where we've got maybe more junior, less confident members of staff will make a decision to admit the patient because they don't have the time and the headspace to think about actually alternative pathways. But equally, you could apply that sentiment to members of the public that are also anxious about their healthcare, and how do they choose where to go? Just thought it was an interesting observation.
I think, yeah, I agree. And I sort of interpreted it to also mean that, you know, we were talking about execs and further up the chain, and decisions they make, you know, can be based on that anxiety and stress, because we all know that there's a lot of stress around achieving the targets, etc. So, you know, there is a lot of firefighting. There are lots of decisions that are made which you probably wouldn't make, but actually they're making because they feel that that is the only way forward. But whether that's a good decision is another matter. It's based on their stress levels, their you know, who they're answering to ultimately. And I think what tends to happen in an ED is very much this firefighting, and you don't step out of that firefighting. You're not able to step out of that firefighting to actually, you know, stop the because it becomes a self-fulfilling prophecy. The more you firefight, it's harder to get out of that. It's harder to step back. And, you know, even trying to find time outside of that firefighting is difficult. But that time would be well spent in terms of understanding how other people are doing it. So whether it's ambulance offloads or whatever. So I think it can be interpreted in a multitude of ways. And you're right, Rachel, clinicians make decisions based on, you know, I haven't got the headroom at the minute, you know, we've got 20 ambulances queuing or whatever, what do we do? So there's a lot of pressure, I think, from all angles.
Yeah. I think the original person has said that they were thinking more of the clinicians, but it's interesting that you can take it at every level, can't you?
Yeah, I think so. Yeah.
I'll just pull this one up. I'm not sure if Alan can get that link, but it's talking here about staff taking things for granted and not really communicating these things. And it's a really good point. And what I find with my work that I'm increasingly doing is it's really, really important to break the existing culture of it's another survey. It's death by survey. This is going to take me an hour. I'm not going to do it because they never listen to it anyway. They never listen to me anyway. The decision's already made. This is a tick box exercise.
Yeah. That
current culture is not great. And that's the biggest challenge actually with Genie, is working with people like you guys and saying, we've got to change that belief that this is all nonsense. Turn that culture on its head and say, we know that we will fail unless we get the real knowledge out of your heads, because it's only your knowledge that will get us from success to from failure to success. That's my real passionate belief, and that's got to come across. And we've got to create that context such that they know they're going to get listened to. And we want their pain points. We want to know what's killing them every day. Don't take that for granted. Tell us about the car park permits. And you can do it. You can definitely do it. But there's some work at the front end of this process to make sure that people understand, and then they will share. If they know they're going to get listened to, and you can create that vision for them of the ideal state and they want to get there, we can generate amazing content out from their brains. And then really we've got the first run is the macro run, and what comes out of it is a massive amount of stuff. And then we hone in and go, right, we're going to start with what might come out of this, Rachel, is we're going to really start on that real engagement with primary care, because now we've got a lot of data on where we think the gaps are and why these gaps are being created. Let's focus there, and then you can do another layer of delving. It's almost like a Russian doll concept of, okay, we've got the macro, now let's delve in and get the real detail again on these specific areas. So that's, you know, if Alan can join that link, I don't know if he's had to go, but that's my first response to him. It's we keep delving. It's not a one-off, and we've got everything, because we'll never capture everything.
Mm-hmm.
I think it's also worth just sort of thinking. We're quite good at saying sort of secondary care and primary care, and secondary care tends to be one thing because it's sort of a trust or a hospital. But actually, there's so many different departments within it. I think it's also important to, when we think about primary care, that actually it's lots of different GP surgeries with different populations, different staffing issues, and so on. So whilst there will be absolutely cross-cutting themes, we want to be making sure that we're thinking about individual partner organisations, not sort of one homogenous care setting.
No, you're right. Absolutely. Yeah. Absolutely. But it's the same for acute, the secondary care as well. I think it's, it's not homogenous at all.
Yeah, sorry, I failed with the link for Ellen. It's a shame. I might, I can get it from this system, but I don't want to shut us down by mistake. So I'm a bit nervous about delving for links. So Rachel, what would you like us to discuss or encourage because we've got some quality people in the audience here. We could pick some brains. Yeah,
no, absolutely. I think there's so many different elements now whizzing around in my head about where we could use this to engage. I'm thinking, I've already made notes here about that primary care interface, actually rolling it out to our ambulance service colleagues as well to understand how we can best support them to use elements around call before convey, which is out there but very underutilised at the moment. There's a big push to utilise that. And understanding what the blockers are. I think Neil's made some really good points in there as well, and I've worked with Neil previously. It's around, to your point as well, Anthony, we're in the realms of organisational development and leadership skills, aren't we really? Because, like you said, death by questionnaire and the suspicion around where the information goes. Actually, if you've already got some psychological safety built in within your team, it's got to be about who's asking for this information as to whether or not you'll get that soft intelligence that we've spoken about that will really drive some of the changes that we need.
Yeah, no, absolutely. And tied into that, I think this is coming up from Esther. It is about culture and that safety. And I don't know about your experiences, but I feel there's a lot of psychological safety issues. Yeah. And the more pressure that comes into the system, the worse this gets. The command and control just goes from over the top to crazy. The more the pressure builds, so it's like discretionary spend. I've got another session on this next month about discretionary spend. The pressure builds. So what do? We add more bureaucracy, more reports, more expectations, more pressure, more time away from actually doing the job. It just gets worse and worse and worse, doesn't it? And we've got to reverse that and say, let's do what matters. Let's focus on the flow. Let's focus on getting things right first time. Rachel's key theme at the start. That reduces a lot of failure demand, enables people to think, get things right first time. It's like a vicious circle down or a vicious circle open and better. And I think we've got to be aware of that, haven't we, before we can make that change. That's what my book's all about, by the way, if anybody's interested in that story. Is there any other points that you want me to pull up? Anybody that you want to drill into?
And there was an interesting one from Neil about surfacing alignments or lack of them. And that is a challenge because it disrupts the way people work. So I suppose it to some extent, it comes back to that sort of management leadership element of how prepared are you for the risks that actually the changes that need to happen will necessitate changes in how people go about their works, whether that sort of changes to job roles or a change of the mix of roles. I suppose that there's a risk of opening a can of worms and discovering something that's going to not only be uncomfortable for you, but actually for the people that are supporting you.
Yeah, I think that's a real point. But if we don't tackle these things are only going to get worse, aren't they? In my view, we've got to tackle them. Got to be open and honest.
I think you're right. I think that it is difficult to be open and honest about things because, like you say, I think there is a lack of psychological safe spaces, etc. And there is always that fear that you're going to be singled out as somebody who's too outspoken or you're not political. And I think it is about this whole thing. I'm a strong believer in you know, this is a bigger thing. This is about the whole system. This is about a reset that's required, and it's going to, you know, obviously require a lot of work to actually do that. And how do you do that when actually, you know, the whole name of the game is treating patients? So it's a real difficult one, and it's got to obviously be done in parallel. But just, you know, what is key until that happens is, you know, the projects, and Rachel obviously is doing one now. So, you know, how do you improve things within your organization, within your system?
Yeah, it becomes, you end up almost paralyzed because the problem is too big.
Yeah.
But actually, you know, you've got to get uncomfortable in order to make the change happen. So which bit do we start looking at that's going to give us a little bit of headspace, and a little bit, you know, we can start proving that we can bring about change in a more positive way that then will engage. So we're not in this perpetual loop of firefighting, responding to a crisis or responding to the next, you know, element that's being pushed down, and actually to hold the line and know what the right thing is to do for our patient population, and carry on with that conviction and with that vision, and push through and bring others along. I think that's our job that's certainly what I see my role as an emergency care leader.
Yeah, no,
is to make sure we're flying that flag.
Yeah, it's brilliant.
Rachel, when you did your 24, oh, sorry, Mark.
No, go on, Anthony.
I was just, Rachel, when you did your 24-hour audit, and 85% of patients should never have come into ED in the first place, did you get more depth of data from that exercise in terms of, okay, who is this patient, what cohort are they in, what are the reasons that they came in for? Did you manage to capture any of that, or was it more basic than that?
It was, yeah, I mean, it was a few years back now, but it was more around, it was, yeah, so what we would have liked to have done, I suppose, now is extrapolate that back to actually see if it was certain populations, certain areas around GP access, for example, that meant that those patients weren't able to contact primary care. Or is it a perception in the public since COVID? There's been a perception that GP services aren't accessible. So had the population just readily decided that I'm not even going to bother with primary care, I'm just going to rock up to secondary care, to the point where now we've got an urgent treatment centre, but we're seeing changes in patient behaviour that are using their urgent treatment centre as a primary care provider. So we're actually starting to get data around regular attenders, although we've got regular attenders from an ED point of view that we're trying to engineer backward with primary care to understand why this potential, you know, cohort of patients are presenting to ED. We've noticing the same patterns of behaviour with our urgent treatment centre as well. So how much of it is human behaviour? What do we do around, you know, communicating out and education around, again, how to, and understanding what's driving that, you know, that behaviour.
Yeah. So all really fascinating stuff, isn't it? Because if the messages are, it's taken me 3 weeks to get access to the GP, you could then just do a little audit ourselves, couldn't we? That is my experience as well. You know, that it is bad. Or no, I've got straight, I've got straight through, and actually it's a comms piece to the community that actually we're not so bad anymore. It's not like COVID times.
And I think there are areas of primary care that have responded really favourably to the needs of their population. But like you say, it's the comms element. And when patients do actually reach out to primary care, they're pleasantly surprised at how easy they found it to, you know, that they can get a Saturday appointment, or they can book an appointment in 2 weeks' time for something that's not urgent. But it's understanding that from a secondary care perspective, so that if we know that about a primary care setting, we can help with that comms piece as well. You know, if we had like a dashboard that showed, you know, in the same way that we have sit reps for acute hospitals that we're on level 3, where this, that and the other, if we almost had the same access for primary care, I think that would be, you know, that would help join the pieces together, wouldn't it?
No,
brilliant.
Yeah, no,
good thought. So we've got a new attendee. Welcome to Ellen. I know Ellen quite well.
Hi, everybody. How are you?
He's an expert in the flow space.
Sorry to interrupt your flow. But obviously, I was fascinated by your conversation. Brief introduction. Auntie and I know each other well. I've delivered healthcare transformation all over the place. So when Wes Streeting talks about Singapore and the culture in Singapore, I, with a colleague who Anthony also knows, put that in place. In NHS terms, I was the national director for transformation a few years ago. So how to help? The first thing is big end-to-end, as you all know, and as you've been discussing, is a huge, it's a holistic challenge, and it must be dealt with like that. So it's not for this conversation, but if MD is interested, and I don't want to distract from the key focus, rightly, of Andy and of Anthony and Jeannie, but if anybody wants to talk about how to seriously talk about end-to-end transformation, that's a separate hour pitch. And I can talk to you about that, how to do that. And all the lessons I learned from the program that I ran. But more usefully, than diving into that, what are some easy first steps? And as ever, the easy first steps are dangerous, right? Because they're not sustainable. So they're absolutely pinch of salt. I offer these easy first steps because, frankly, if I was you, I wouldn't do them. I would understand how to do it properly. But here's some easy first steps to reflect on. One of the exercises I would do with an executive team, and it would probably start in the trust, but then use the executives to go beyond the walls of the trust, Rachel, to the GPs and the GP community and the ambulance trust and the care homes and so forth. And hopefully you can picture this very simplistically. And I don't know if I can paint this picture, and please stop me if I can't. If you think about the nodes of healthcare, prevention, the GP/primary care, ambulance trust, ED front door, outpatients front door, wards, discharge, with some what I call pool facilities. Some people might need theatres a node, right? Okay, diagnostics is a node, pharmacies a node. Can you picture that? There are these nodes of a process, and sitting above those nodes is how we control flow. So bed management is a classic example. So, and if you can picture, and I don't know if I'm painting this, I apologize if I'm painting this poorly. There are three lines. There's the delivery line, there's the governance line, and there's the support line, right? So most of those nodes I've just talked about on the delivery line, so prevention, GP, front door, ward, they're the delivery line, yeah? Things like diagnostics, pharmacy, IT, HR, they're support nodes, and bed management is a governance node. It's thinking about flow. So I'd go to the executives and I say, okay, stick a piece of paper, a piece of A4 paper on the wall, and show me the key data for each of those nodes. So let's do an easy one, which happens to be a hard one, the ED, right? So immediately they're going to probably reach for classic metrics like the 4-hour target or whatever it might be. But the metrics I'm really interested in are process metrics. So demand. You said you're in good shape at the moment in summer, right? But here comes winter, yeah? So clearly demand is a metric, right? And one of the things that I believe is that trusts actually probably do better in winter than they do in summer because their performance, their productivity, if you will, is probably better in winter than it is in summer because they're trying to meet the demand, right? Okay. So in terms of actual productivity, it's probably better, but they're chastised for being worse because the demand's so high, if that makes sense. Anyway, so demand's clearly the shape of demand, the elderly, youth, whatever, the shape of demand on, here comes Friday night at 11 o'clock, here come the drunks, whatever, right? Okay. shape of demand is really important, so understanding demand. Then the next big metric through any of those nodes is flow time. Show me the picture of time it takes to go through that. And they've probably got that data, right? Okay, because that's what feeds 4-hour targets and all that sort of stuff. The next metric is what I call the touch time. So the touch time simplistically is, okay, if I'm in, and it's kind of reflects how a patient would talk about the ED. They'd say, I was there for 4 hours and I saw a doctor for 10 minutes, right? That's how patients talk. And all I'm using is posh language to do just that. Flow time is, I was there for 4 hours. I saw the doctor for 10 minutes is touch time, right? Okay.
Yeah.
And so, and then the last one, and Anthony, is one of Anthony's favorites, which is right first time, failure demand, right? Okay, so I went to the ED, I had my arm fixed, but I had to come back the next day because the plaster wasn't put on properly, right? So failure demand. So what I'm focusing on there is I'm focusing on process metrics, not those metrics. So the flow time, the touch time, the right first time, right? Okay, failure. How many times did Mrs. Jones come back? Right. Okay.
Yeah.
Those are really the other. I love balanced metrics. So 4-hour target's a completely flawed metric and should be banned from the NHS. The reason it's such a flawed metric is because it's not balanced, because anybody can hit the 4-hour target if you give me enough people and enough money, right?
Yep.
Anybody can hit the 4-hour target, but I might kill a bunch of people, right? Anybody can hit the 4-hour target, but the staff have got to be there 24/7, 365 days a week. So any target is only proper if it's balanced. It's 4 hours is what I call a delivery metric, right? Okay, the money, the amount we're investing in it, and that's the easiest way to get a handle on money is the number of staff you got, right? Okay, that equals money. So money, delivery, money, quality is back to right first time. So I'd come back and have my arm fixed. And delivery is the working hours of the staff and the number of people who are going sick and in the ED and so forth. So what I'm saying is for each of those bits of paper, show me those data, right? So X-ray, average in X-ray. Here's the demand in X-ray. It's mostly broken arms and broken eggs. Yeah. So it's all the same stuff. Here's the demand in X-ray. What's the flow time? What's the flow time picture through X-ray? What's the touch time picture through X-ray? What's the right first time through X? You get their picture.
Yeah.
And when you start to understand with those process metrics, not NHS metrics, those and you put those metrics on each individual bits of A4 paper, bed management, right? So ask yourself, and you'll develop an end-to-end picture. And you'll develop a fascinating end-to-end picture for your execs to bring GPs and care homes and so forth into, right? Okay, to say, look at this.
Yeah.
Just look at this. And then we've started a conversation, a really important flow conversation that we tend not to do because we're so focused on reporting to NHS England and regions on our 12-hour waits, 12-week waits. And
Yeah.
So break that part down.
Right.
The third one, and then I'm going to shut up because this, after all, is Anthony's gig.
It's a really nice contribution. It's bringing us all together.
Okay. The third one is, and I would show you a lovely video. I'll send it. I'll put it. I don't know if I can now do it. I was trying to. I've got a pitch on firefighting as well, which I can help you with, which is a separate kettle of fish. and also on. But there's a lovely video that I'll try and stick on this by a guy called Sir Ken Robinson, and he talks about, and he was a fabulous guy who talked about mostly about education actually, and he talked about the problem with taking stuff for granted is we take it for granted, right? And so one of the biggest challenges you've got as you take Genie into the workplace is stimulating, making the people in the system conscious, right? It's kind of like, you know how, I don't know if you've ever done any meditation or mindfulness or any of that. You suddenly you're kind of meditating on the process. You're becoming conscious of the process. So you got to make people conscious of what they're taking for granted every day, right?
Yeah.
And the easiest way to do that is the easiest way to do that is what I call the flow of improvement process. And it is the simplest process that is where all improvement should start for any team. If I could get 1.5 million people doing this in the NHS, it would be a much better place. And it's 10 minutes training. And there are 4 steps, 2 of which the teams already do. So what's the first step? So the first step is you've got problems. You know, I've got a problem. Alan's come in and he's got a broken leg. Here's my problem, right? Okay. And the second is we solve the problem. We take him to X-ray. We put his leg in plaster and we send him home, right? Okay. But in the middle of that process, we ran out of plaster of Paris, and there was 2 hours in the middle of that process where we ran about, oh, we've run out of plaster of Paris. I'm sure you don't even have plaster of Paris with broken leg these days anyway. But you get the idea, right? We run about and we find some plaster of Paris and we fix Alan's broken leg. But it added 2 hours to Alan's process. Most organizations stop at that point. Problem, broken leg, solve it. Problem, solve it. Problem, solve it. Problem, solve it. World-class organizations do 2 more steps. The next step is increasing the consciousness of the staff. Any problems today, guys? Yeah, we had to run around for plaster because we ran out of plaster of Paris for Alan's broken leg. Write it in a list. Just write it down. 2 minutes. Any problems today? Yeah, Mrs. Jones's family didn't come to pick her up. Okay. Yeah. Oh, Mrs. Smith's discharge jugs were late. Okay. That's all I want.
And Alan, that's essentially my drive and passion with Genie is to capture those.
It must be driven by their daily work, right?
Yeah,
okay.
Absolutely.
And the best way to do it so if I'm running a ward, how many are we trying to discharge today? We're trying to discharge 10. Next morning, how many did we discharge? We discharged 8. Why? Oh, the drugs were late. Okay.
Yeah.
Yeah.
Right?
Mm.
So third step is, and that just increases consciousness. Now, the fourth step is clearly to reflect on those and, oh, look, we keep running out of plaster of Paris. Oh, look, discharge drugs keep being late. Oh, look, right, okay. And then we're off, right? Whether we're doing it through the team thinking about it or using Genie. Now, the beauty of a thing like Genie is that you can start to join the dots. So if all those nodes I talked about, like ED and wards and pharmacy and are doing that process and sticking it into Genie, right? Not only can it help the node improve, but it can look at all the nodes and say, shit, if I could, they're having the same problem as them, and right? And it can think in terms of flow. You can train it to think in flow. And that's the future of a tool like Genie.
Absolutely. Yeah,
right?
Brilliant. Really,
So,
really,
I
really,
apologise.
really helpful,
I'm
Alan.
too mouthy, but there's a few thoughts. The three.
No,
things.
it's really, really helpful. I'm just conscious that we should have stopped 4 minutes ago. So I'll come back to Rachel and just ask how you want to take it forward, Rachel, and what you'd want to, if you want to pick Alan's brains whilst we've got him before we go.
Yeah, I mean, there's lots of elements there that absolutely resonate with me. Around, I mean, it's an area that we have been looking actually. You know, that process element, as you've just described, and getting really deep into that. As I say, I think that the whole Genie thing can be used to get so much information. I probably actually don't know where to start first with it, if I'm absolutely honest. But I think for the purpose of the winter planning, definitely like the idea of getting that involvement with primary care and understanding those elements around our failing system and what we can do to rectify that fairly quickly in time for winter, notwithstanding, you know, we haven't got time for investment, business cases, etc., etc. There's stuff that we can do in the here and now that will improve this winter for our patients. That's the thing that I'm going to major on after this.
Brilliant.
Yeah.
And if you wanted to, Rachel, I could set up another Genie that we could sort of context around that, and then maybe we could all write some posts this week, feed them out, and try and get that movement in primary care.
Yeah.
Or focus on a primary care initiative and try and glean as much as we can.
There's a few interfaces and meetings that I've got that I could probably already push things out to as well. So yeah, keen to look at that. Thank you.
Yeah.
Okay, brilliant. So we'll catch up. We'll do the work. We'll reach out to as many people as we can, and then I'll definitely feed back on LinkedIn in terms of how we're progressing, and Rachel can maybe feedback, and maybe we do another follow up one of these in, you know, not July but the end of August maybe, if everybody wants to do it. It'd be interesting just to do a follow up.
Yeah, good idea.
Okay, brilliant. Thanks everyone. I'm just conscious that you've probably all got meetings to go to and you're 6 minutes over. Typical NHS scenario.
Thanks, guys. Thank you.
Yeah, thanks ever so much, and thanks for people in the audience. And the link to contribute to the Genie that we've already set up, if you want to, just spend 10 to 15 minutes brain dumping. That'd be great, and I can use the chat comments as well to support the analysis. So thanks ever so much, everyone, and keep posted on LinkedIn, because I'll set another one of these up in maybe end of August. That's great. Thanks, guys.
Thank you.
Have a good lunch.
Thanks, everybody.
Bye.
Bye-bye.